Today I'm Dr. Mustafa Jisruman. Welcome you all in our today's session. As you know, today's point of discussion will be biological targeted therapy in advanced stomach cancer. Just a minute, our professor Haisar is joining. Formally শুনে শুরু করি। স্যার আপনি কি শুনতে পাচ্ছেন স্যার?
হ্যাঁ শুনতে পাচ্ছি
স্যার, আমরা শুরু করি স্যার।
হ্যাঁ শুরু করো।
So today's our presenter will be Dr. Jahangir Alam. He is a medical oncologist. He has obtained his MD in medical oncology from National Institute of Cancer Research and Hospital. And after completion his MD degree, he obtained a one-year-long fellowship in Rajiv Gandhi Cancer Institute. So today, as it is a very newer topics, that's why we are not going in formal way with some poll questions. So today there will be no poll. So after the presentation, we'll directly discuss these issues with our panel of experts and our very senior teachers who are present there in the Zoom platform. So without any delay, I would like to request our today's presenter, Dr. Jahangir Alam, to present his discussion. Dr. Jahangir Alam. Jahangir, make it full screen. Okay, Jahangir, you can start.
Jahangir, unmute.
Jahangir, you have to unmute yourself. Dr. Jahangir Alam, you have to unmute yourself. Dr. Jahangir Alam, can you hear me?
Okay.
Okay.
Am I audible?
Yes, you're audible.
Yes.
Right now.
Okay. Honorable Chairperson, distinguished guests, and respected teachers, my dear colleagues, Assalamu alaikum. Welcome to my session, Biological Targeted Therapy in Advanced Gastric Cancer. Pan-Asian SMO guidelines in metastatic gastric cancer, having palliative chemotherapy and best supportive care options. In this stage, we should do HER2 status first. Those who are HER2 positive patient, we should treat them with trastuzumab plus fluoropyrimidine and cisplatin or oxaliplatin in first line setting. Now, let's see in details the role of HER2 directed therapy. Here you can see trastuzumab combined with chemotherapy and produced better overall survival, that is 14 months in TOGA trial. TOGA trial is the first signature trial by which it is established that trastuzumab is standard in HER2 positive advanced gastric cancer. Here you can see the median overall survival 16 months in trastuzumab combination chemotherapy and 11.8 months in chemotherapy alone arms. That is, addition of trastuzumab with chemotherapy produced significant better overall survival. Now, the question will come whether trastuzumab combination therapy can be treated by the elderly or frail patients. Here in this Japanese study, we can see trastuzumab combined with S1 alone. The median overall survival is 15.8 months. That is similar to overall survival of TOGA trial. We know that overall survival of TOGA trial is 16 months. So far, patients elderly or frail or intolerant platinum, we can consider trastuzumab with 5-FU based single agent combination. Here, trastuzumab trials with different types of combination is most common is Xalox and produce better overall survival. So Dialogues with trastuzumab should be the standard of practice in advanced gastric metastatic cancer. Now, should he continue trastuzumab after progression? Here you can see that T-ACT study proved that no role of trastuzumab beyond progression. Here, paclitaxel with one arm and paclitaxel and trastuzumab in the another arm. Look, the overall survival, there is no significance in overall survival, and hazard ratio is 1.23 and p-value is 0.2, that is not significant. So no role of trastuzumab beyond progression, or that is loss of HER2 expression may contribute to lack of response to trastuzumab. What is the role of trastuzumab in second-line metastatic gastric cancer? If the patient is not tolerated with trastuzumab in very first line, we should consider trastuzumab in second-line metastatic gastric cancer. As you can see, in second line, trastuzumab produced overall survival around 17 months and PFS 5.1 months. Is there any role of trastuzumab in third line? In Destiny trial, Japanese scientist Mr. Shitara showed that trastuzumab combined with deruxtecan produced better outcome in third-line advanced gastric cancer. Here it is also must, patient had not previously received anti-HER2 treatment. The percentage of patients with an objective response was significantly higher in the trastuzumab deruxtecan. Overall survival was longer in the trastuzumab deruxtecan group than in the physician's choice group. Notable adverse events, myelosuppression and interstitial lung disease. But this is approved only for Japanese population for HER2 positive advanced gastric cancer. Finally, HER2 positive advanced gastric cancer should be received trastuzumab in first line and second line setting, and trastuzumab deruxtecan may be considered in third line or beyond. What else do we have except trastuzumab? Have a look. Pan-Asian ISMO guidelines on second-line metastatic gastric cancer. There are ramucirumab and immune checkpoint inhibitors in the second-line metastatic gastric cancer. In regard study and rainbow study, it is established that a good role of ramucirumab in advanced gastric cancer. Ramucirumab produced better overall survival as well as progression-free survival and objective response rate also. There is another emerging target in gastric cancer, the NTRK fusion. It is mostly in Asian population. This abstract is published in ASCO 2020 and showed the role of larotrectinib in GI malignancy. This is another target, NTRK fusion, and entrectinib also shows better outcome even with CNS metastasis in GI malignancy. So, in brief, we can conclude that HER2 positive patients should be treated with trastuzumab from first line advanced gastric cancer. And in second line, we should consider ramucirumab and immune checkpoint inhibitors, pembrolizumab, nivolumab, but NTRK infusion drug still under investigations. Now come to immune checkpoint inhibitors in metastatic gastric cancer. We can see these different types of immune checkpoint inhibitors in third line, second line, even in first line treatment of metastatic gastric cancer. Here, all red marks are positive trials and black marks are negative trials. Let's see immune checkpoint inhibitors in third line. Here we can see keynote 059 trial with pembrolizumab and attraction 2 trial with nivolumab versus placebo. From these two, we can find that immune checkpoint inhibitor monotherapy is better than placebo, but not superior than chemotherapy. Another trial, Javelin, showed that immune checkpoint inhibitor is not superior than chemotherapy. In second line, keynote 061, pembrolizumab compared with paclitaxel and found non-significant. Here we can see progression-free survival is better in chemo than immune checkpoint inhibitor if CP score is 1 or more. And in subgroup analysis, those who CP score 5 or more resulted better with pembrolizumab than chemotherapy. Let's see what immune checkpoint inhibitors in first line. We can see keynote 062, keynote 062, checkmate 646, attraction 2, and Javelin gastric 100 trials. Among these 4 trials, checkmate 649 and attraction 2 are positive trials, and keynote 062 and Javelin gastric 100 trials are negative trials. In keynote 062 proved that pembro is non-inferior than chemo, but pembro and chemo failed to prove better overall survival. Keynote 649 trial nivolumab with Gelox or Folfox in first-line advanced gastric cancer. Here we see immune checkpoint inhibitors with chemotherapy combination is better in overall survival and progression-free survival than chemotherapy alone. In this forest plot, we can see benefit of nivolumab is independent of PD-L1 expression. Attraction 4 trial is an Asian trial, nivolumab plus capox versus capox alone. Look, the median overall survival in nivolumab plus chemotherapy arms 17.45. On the other hand, chemotherapy alone, median overall survival 17.15. So there is no benefit in this trial also. By these studies, we can find that immune checkpoint inhibitor is not as promising as it do in the other subset. Now see how we can improve the outcome with immune checkpoint inhibitor. Here molecular subgroups, Epstein-Barr virus associated gastric cancer, microsatellite instability, and PD-L1, etc. And most significant is microsatellite instability. We can see keynote 061 and 062, those who are MSA high produce better outcome. Till date, MSA is the most significant biomarker for selecting immunotherapy in gastric cancer. In my conclusion, there is a role of immunotherapy in gastric cancer, but very small subset. So need to clarify the proper subset. Immunotherapy monotherapy is too weak or modest effect. So need to find proper combination partners and sequences, and need to understand the immunogenetic biology that is slowly progressing. Still early to give up immunotherapy for gastric cancer. Thank you for patience hearing and keep safe.
So thank you, Dr. Jahangir Alam. Can you off your screen sharing? The screen sharing option, Dr. Jahangir. Okay, so thank you, Dr. Jahangir Alam. By this time, our overseas faculty, Dr. Jayed Khan, has joined. Let me introduce those who are new here, who are joined, who did not just 2 sessions. Dr. Jayed Khan is a senior medical oncologist working in the Clatterby's Hospital. So he is a
Shubhan, unmute yourself.
Okay, so there is a. Can you hear me? Zahid, can you hear me?
শোনা যাচ্ছে না, এখন শোনা যাচ্ছে।
Assalamu alaikum. Yes, I can hear you, Shimon. I'm sorry.
আমাকে কি শোনা যাচ্ছে কামাল ভাই?
মাঝখানে ডিস্টার্ব ছিল,
Okay.
শোনা যাচ্ছে। মাঝখানে একটু ডিস্টার্ব ছিল, এখন
Okay,
শোনা
Zahid
যাচ্ছে।
bhai. Okay. So as this is very new, I don't have any experience from myself. So I think we will discuss some of our senior medical oncologists, senior clinical oncologists over here in Bangladesh. They are now joined over there. I have seen Professor Mufadzul Hossain sir, Selim Reza sir, and Torit Kumar sir. So we will take some real life practical experience from them. So at first, I would like to ask a question regarding the trastuzumab therapy. Mufadzul sir, can you hear me, sir?
Yes, I can hear you.
Sir, in your clinical practice, how many percentage of patients you frequently found HER2 positive in advanced stomach cancer?
Right. Routinely, still, we are not carrying out HER2 in every patient with gastric cancer. That is
Sir.
true for every consultant of this country.
Yes.
I'm sure. But those who can afford, and there is relapse of disease, at that time we try to find out the tissue and carry out this test HER2. I have used HER2, anti-HER2 therapy in few cases of gastric cancer, but the results are not very promising. I do not actually, I will not recommend this treatment for middle class and lower middle class people of this country. But those who can afford, those who have plenty of money, they can try it, even if there is 2-3 months progression of their life. They can buy it, fine, no problem. So far as the other molecular test, PDL1, then microsatellite instability, MMR, these are not being carried out. We are now probably in a position to check at least PDL1 because this test has started. And you know, my point is gastric cancer is not a very common disease in the affluent group. It is our middle and lower middle class, those who suffer maximum. So they neither can afford this costly test, but to talk about the therapy related to this immune. We are using the common chemotherapy that has been mentioned. We are using oxaliplatin based chemotherapy. EOX I have already mentioned in the previous conference. We use Gelox, we use irinotecan. These are active drugs. We get good results out of this. I have used FLOT in many cases with quite impressive results.
So thank you, sir. So
if you ask me, I will say our experience is meager, but with the passage of time and availability of these drugs in our country, if at all the drug costs are reduced, probably we will be able to say in few years ahead of us about the true occurrence and the result of treatment with this molecule.
Thank you, sir. Sir, we will come again with you regarding the immunotherapy. Let's discuss about the trastuzumab therapy, sir. We'll again come to you regarding this immunotherapy issues. So, as per Professor Mufadzul Hossain sir, he is the senior most medical oncologist over here in Bangladesh. He is not in very favor of using trastuzumab therapy. Selim Reza sir, can you hear me, sir?
Selim bhai.
Selim Reza sir. Okay. Torit Kumar sir, can you hear me, sir? Torit sir, can you hear?
Unmute kore.
Yes,
Sir, what's your experience regarding the trastuzumab therapy?
I got only 2 patients in my life in Dhaka when I was posted in Dhaka. But those 2 patients were advised to get to take Herceptin or trastuzumab therapy, but they refused to do it due to financial constraints. So I cannot apply those trastuzumab to these patients. But ultimately, only I followed those two cases for the next 3 years. But after conventional chemotherapy, the patient will feel better than before, because although they do not take the trastuzumab therapy, even they still they are alive. One patient from Chittagong and another patient from Brahmanbaria, so they still alive after getting the conventional therapy.
So without
Getting the
trastuzumab
trastuzumab therapy.
Okay, sir.
This is the message.
No, sir. Okay. So your message is that without trastuzumab therapy, even a certain percentage of patient,
Yes,
we can achieve a certain benefit.
yes.
Thank you,
Yes,
sir.
yes.
Yeah. So Kudrat Hilai, sir, he is the chief of medical oncologist in CMH hospital. So Kudrat Hilai, sir, can you hear me, sir?
Yes, thank you very much.
Sir,
In gastric cancer, usually as we go for hard to test, but rarely we get positive. Number one. Number two, yet we have not used trastuzumab for those patients to get benefit. We are using conventional chemotherapeutics. And regarding immunotherapy, we are using immunotherapy other cases, but not for any gastric cancer so far. So our experience is not very encouraging. I see.
sir,
That is from on behalf of me.
thank you, sir. Dr. FM Kamaluddin, sir, what's your experience?
But nothing different. I mean, from the same soil, same experience. So, I mean, we are not a big fan of trastuzumab like breast cancer, but even the TOGA trial is having a strong evidence. But the question is, you know, if you look at the TOGA trial, the median is 9 dose of trastuzumab from 1 to 48. So they have followed it up 4 years, and the benefit is only 3 to 4 months. But as like Dr. Tarik Samaddar, I can say that our experience of second line, third line with the conventional chemotherapeutics without using the biologics, we have, I mean, pleasant experience, I would rather say, in stomach cancer. So unfortunately, personally, I have no experience of trastuzumab, and I think till now, I mean, as Professor Mufaddal was telling, the cost of the drug and the offered benefit may be a big barrier for trastuzumab in gastric cancer, because we know the OSA, we don't expect more than a year in advanced cancer.
So thank you. So from our Bangladeshi perspectives, all the senior doctors are saying that they are not in very favor for trastuzumab therapy. So Dr. Zahid Khan, you are a mixed character. You are a son of this soil, and now you are practicing in UK. So what's your suggestions regarding this trastuzumab therapy?
Thank you very much, Shumon. Can I please first congratulate Dr. Jahangir? That was a really beautiful presentation. Sorry, I couldn't be present from the start. I think I caught up from when you were talking about the second line HER2 treatment. You've really summarized all the important trials, and it's really difficult. Before I go into that, just to quickly that it's really difficult to navigate through the evidence that's available in biologicals, because you cannot compare two trials. The chemo backbones are different. The CPS scores assessments are very different. So trying to pool information from all these trials together and make a conclusion is really difficult. So coming to the HER2, so number one, we know that it's quite variable depending on where your primary is. If you have a more gastric primary, your HER2 rate is lower. I think Toga mentioned about 20%, but I think the real world, our experience is about 15 to 20%, but it goes higher if you go to the GOJ. Then again, Toga suggested 30%, but our real world experience is probably 20, 25%. So roughly about 1 in 5, 1 in 6 gastric cancer patients or GOJ, you'll have HER2 positive. And obviously the constraint in Bangladesh is the financial toxicity, where the patients can afford. Whereas I enjoy, it's a taxpayer-funded health system where if someone is HER2 positive, we are able to treat them. but we are only allowed to treat as first line because the evidence from the second line is not that convincing. And also in the third line is only sort of licensed in Far East Asia, not in Western world yet. But deruxtecan is being assessed in other cancers. So I believe sooner or later, it will probably make more headway. So again, what I can tell that HER2 positive cancer, in contrast to breast cancer, in gastric cancer, they actually tend to behave better. So I think one of your panelists mentioned about that even without Herceptin or HER2 target therapy, with conventional chemotherapy, they still do reasonably better. And that is also our experience as well. That if there's any reason for cardiac comorbidity, we're not able to give the Herceptin, actually standard chemotherapy can still provide them a significant overall survival. So I would agree with that. So far in last 7 years, I had probably about 15 to 20 patients, and their median survival was beyond 2 years, and that's really good. It's really fabulous compared to if we just think about what happens to just advanced gastric cancer, their outcome. They do better. I hope that answered the questions.
So Kamal bhai, I have seen you have raised your hand. So what's your point?
So I want to supplement with Zahid that I want to say about the juniors. Zahid very silently uttered a very important message that HER2 is not yet proved to be a very big detrimental factor like breast cancer and gastric cancer. There is a big debate and there is no conclusive comment that HER2 positivity is a detrimental thing. And the behavior of gastric cancer of HER2 is not like breast cancer. So, and country like us, where we always look for this type of biologics on second and third line, this is not a big, the strong data is not in favor of second line. So, I mean, I want to reiterate again my comment in favor of not being a very big fan of HER2, targeted therapy in gastric cancer because of all these points I want to, emphasize after the comment of Zahid that breast cancer, HER2 is a bad news. Maybe it is not. And number two, it is not very good in second line where we look for a new molecule. And third, 3 months benefit with this cost may be issue. But Zahid, I want to have a comment from you that if you look at the TOGA trial, the median is only 8 to 9 cycle. And that had achieved. So, you know, in breast, there is a big debate of 6 months versus 12 months. So do you think that there is any possibility of, say, just thinking loud, that any short course of this can make any, is there, I don't see any, I never saw any reference. Is there any such reference? Just to know.
Well, as far as I'm aware, there isn't any evidence to shorten the duration. So this is interesting that in breast cancer, you have so many trials with HER2 targeted therapy, whereas in gastric cancer, we only have this TOGA and nothing else. And nobody has tried to come back and say, okay, let's do a 3 months, 6 months, 12 months treatment and see what we can achieve. So we don't know the answer. So as I go back, that overall is good prognosis, generally compared to non-HER2 secreting gastric cancer. So if people can afford whatever duration that can afford, I think that will be a bonus.
So my question that HER2 was doing good, but pertuzumab addition didn't do good.
No, and lepatinib, I think there's a question I've seen about lepatinib. So there again, there is no proven role of these two drugs.
So is it, do you think, is it the biology? Because all these molecules proven good in breast in HER2 positive, but gastric, neither of the molecule except trastuzumab failed to, even mTOR failed to show any survival benefit. So what is your take on that?
I think the way that we understood, or at least the science has discovered more about the biology of breast cancer, I don't think we haven't got to that point with the gastric cancer yet. So we are only talking about now the PD-L1 and MSI, things like that. But actually, we still haven't understood fully about the biology. So why is behaving differently? Obviously, the answer is biology. When we understand more about it, about gastric cancer, when we can find more actionable targets, I think that might change the picture in future. So right now, I think our knowledge is not as good as we have in breast cancer.
So let me summarize all the discussion, Zahid bhai with all the seniors. So if we can summarize that if a patient, for the all common people, if a patient come to me with a advanced stomach cancer, should we go for HER2 status first? Yes or no?
If the patient can afford in a system where the patient is paying for the healthcare, then the answer is yes. As I've said, I come from a slightly different healthcare system where we are not able to throw everything that the evidence is suggesting. As I've said, that we are not allowed to use HER2 targeted therapy in second line or third line, but we can use in first line. So that is funded within the healthcare system.
So before giving the HER2 status, we need to discuss with patients whether he is able to buy this type of drugs for these few months. So if we can afford, then we should go for the HER2 status. Otherwise, we should not advise this HER2 status. Am I correct?
Yeah, I think it will be a big regret if a patient doesn't HER2 and say, "Oh, I can't afford the Herceptin now." I think that will leave them with a big regret that maybe I wish if I had more money. If I can sell my house, if I can sell my land. And so, yes, I mean, the amount of healthcare in Bangladesh, I can't imagine that if I go back, I don't think I'll be able to afford it.
Definitely. So I think there's the take-home message from regarding the HER2 therapy, that the trastuzumab, though the TOGA produced some better overall survival, but still regarding the cost, as I like to echoes with Professor Mubatir Hussain sir, that the trastuzumab therapy is not very promising considering the Bangladeshi perspective, as we don't have any reimbursement policy. Not only the trastuzumab, or the others HER2 directed therapy like lapatinib, even the TDM1 is not produce any overall survival benefit. So I think we should be very cautious regarding the HER2 therapy, particularly for gastric cancer. Now we need to move another promising drugs, that the immunotherapy. At first, I would like to ask the question to Professor Mubatir Hussain sir. Sir, what's your experience regarding immunotherapy in gastric cancer?
Well, I have used only in 2-3 cases pembrolizumab. Those were prescriptions from Singapore, and they got the drug from Singapore. But as you all know, this is given in second line metastatic setup. So the results were not that good. I was not impressed. And with the other drugs, that is nivolumab, I have not used in stomach. I have used nivolumab in renal cell carcinoma and HCC, but not in gastric. And pembrolizumab I have used in lung cancer, but in gastric I have said in 2 to 3 cases only. So this experience will not reflect the results as has been shown in the studies presented by Dr. Jahangir.
Thank you, sir. Zahid Khan bhai, I have said, Zahid bhai, you have to unmute. Zahid bhai, you have to unmute. Zahid bhai, you have to unmute.
Before I answer about the immunotherapy, can I ask, is biosimilars available in Bangladesh, the Herceptin biosimilars? Because NHS is not paying anymore a single penny to
All
Roche.
biosimilars are available in Bangladesh.
Biosimilars are available.
And is it any cheaper or affordable?
A bit cheaper, but not affordable.
Pembro has been recently introduced, a little cheaper, not
affordable.
Right.
Okay. So I was just going to say that NHS doesn't pay for the trade drug anymore. The NHS is actually using biosimilars just to save money. So coming to immunotherapy, Shumon. So as Dr. Jahangir has gone through all the first line, second line, third line trials, it's very complex to compare one trial with the another. If we think about the keynote trials, they have looked at the CPS scores. If you look at the attraction trials, they haven't done any PD-1 assessment. If you look at the checkmate trial, they have done a different way to assess. They have used a TPS score rather than the CPS. So how do you compare these trials is difficult. In the keynote trial, the chemotherapy backbone was cisplatin 5-FU, whereas in checkmate, you have used oxaliplatin, capecitabine, or oxaliplatin and S1. Okay, now we have, if we think about our previous discussion where we talked about just the chemotherapy treatments in gastric cancer, I think we established that oxaliplatin and fluoropyrimidine is probably the best option compared to cisplatin and fluoropyrimidine. So again, how do you extrapolate one information from one trial and combine with the other one? But again, if we combine all these three settings of trials, the first line, second line, and third line, there are two things that comes out very straight away. Number one, immunotherapy is not really helping adenocarcinomas, okay, unless the CPS score is more than 10, or unless the tumor is MSI high. Okay, I think these are the two. I think there is a paper which has looked at all the MSI high patients from the keynote trials, and they have actually the most benefited group. So in UK, in our practice, we are not allowed to use immunotherapy unless a tumor is MSI high or deficient MMR. So that is our practice.
So thank you, Dr. Zahid Bhai. So now I would like to request Kudrat Elhai sir. What's your experience regarding immunotherapy, sir?
Thank you very much. Actually, I have no experience with immunotherapy in gastric cancer, but we have some experiences with other cancers. But in gastric cancer, we have not used any immunotherapy.
Sir, suppose you are in a scenario that you can, your patient can afford, and you are in a indicated scenario, whether you are going for this immunotherapy or not.
Well, we can use it because there are some indications. So if there is indication and the patient can afford, we can use it. There is no problem. Because we will follow guideline, of course.
So thank you, sir. So if it is within the guidelines, sir, you are within favor of this using this immunotherapy.
Yes, there is no doubt.
Okay. So Torit Kumar sir, what's your opinion regarding using this immunotherapy?
I have no experience in using immunotherapy for gastric cancer. So if guidelines tell us, then I can use in future.
Okay, before going in details, I just want to discuss regarding these two issues. That's a CheckMate 649 and Attraction 4. The CheckMate 649 European study, it produced 3 months better overall survival, 3 or 4 months in the European population. And the Attraction, though it is not significant, but it's produced more than the overall survival than the European standard. So European patient really need immunotherapy, Dr. Jahid Khan. Sorry, Asian patient.
That's a very good observation. We have seen consistently that the Asian patients do much better with immunotherapy compared to Western population. And I think we briefly talked about it on the last session, that there must be some difference in our biology between the Asian patients and the European patients. While they are, so if I can remember, 17 months, wasn't it, their median overall survival?
Yes, 17.
So it's incredible. It's incredible. And even in the chemotherapy arm, their median survival was the same. But obviously, you could argue that patients, when progressed on chemotherapy, they actually received chemotherapy afterwards. So whether that was the confounding factor or not. So in my experience, I'll say two things. Number one, immunotherapy alone has got a lower response rate compared to immunotherapy plus chemotherapy, or even chemotherapy alone, okay? So immunotherapy alone should not be used in patients who's got high volume disease burden or symptoms, because it's not going to achieve. I think the response rate was something around 15% in immunotherapy and 20 to 30% in chemotherapy. So you can see that the response rate is actually better with the standard chemotherapy. And the second thing is that a significant proportion, I think I'll probably say a quarter of people, they progress through the immunotherapy. And again, if you look at the curves in the second line and in the first line setting, that the immunotherapy drops down. And then when it comes to about 12 months, that's when the immunotherapy pick up, okay? So that means that actually you have to give a patient between 10 to 12 months to actually see whether it's actually benefiting that patient or not. And for nearly a year, a patient will have to suffer through the side effects of immunotherapy and obviously the cost of the immunotherapy. And then you find out the people who has responded to immunotherapy, they are the ultimate winners because they have a longer disease control and then they have a longer overall survival. But to get to there, you have to treat patient anything between 6 to 12 months. And I can't imagine how many patients will be cope with that, even in the Western countries. So I think even in Western world, we are a bit skeptical about immunotherapy in gastric cancer. As I've said, that if it's a pure adenocarcinoma, and if your CPS score is 1 to 5, then actually I don't think in Western world people will be very enthusiastic about treating people with immunotherapy.
So thank you, Zahid bhai. Zahid bhai. Let's ask you the question very straight. So suppose you are in Bangladesh, you are practicing whether there is no reimbursement policy. So should you practice immunotherapy in first line?
Immunotherapy alone or immunotherapy with chemotherapy?
Combination chemotherapy as with ATRAC4 or as is checkmate 649. Anyway, anyone, whether you are go with this.
Okay, so if money is not a problem, and if the patient is fit and there is no contraindication, if the CPS score is 10, okay, or MSI high status, then yes, I will go for immunotherapy plus an oxaliplatin-based chemotherapy rather than the cisplatin-based chemotherapy. Okay, so remember there are a number of conditions. Number one, as you've said, money is not a problem. Okay. Number two, it's MSI high status or CPS 10 or above. Okay. These are the two reasons that I would probably prefer immunotherapy plus chemotherapy. However, if it is a low volume disease, okay, and the patient is largely asymptomatic or very little symptomatic, then that might be the reason you could go for a single agent immunotherapy. Does it answer?
Yeah, okay. But before the question, I have mentioned 2 points. You are in Bangladesh and no reimbursement policy. So very diplomatically, you have avoided this question. But
no, I've said if the money is not a problem, I say. But if it is the patient is not able to afford immunotherapy, I'll forget about it completely.
Come on, I want to jump into the discussion. Zahid, let me politely disagree with you. If I pull the evidence, see the checkmate study, only 15% was Asian population. But attraction is totally Asian population. But in attraction, they have achieved DFS, not OS. And as you said, repeated chemotherapy use may be the reason of long OS, even 17 months, which is incredible. So, when it is a big hot cake for first line with chemo, with CPS score more than 10 to use immunotherapy, will you be that much tempted to use it in Asian population? Forget about money, because attraction is not giving big attraction because it is only DFS. It is not showing OS. Like the checkmate. Checkmate have shown OS and there only 15% is Asian population. Here it is Japan, Taiwan, and China. So pure Asian population. So, as we have seen that we discussed in earlier session also, maybe there are some genetic issues like EGFR in the Asian population where gastric cancer or the GI cancer is behaving a bit different. So, if I want to make a devil's advocacy, forget about the reimbursement. Is it not that robust like the Western data for Asian population to use on first line? Second line, it's okay. The first line with chemotherapy, shall we go for it? That is my question.
Very good. As I've said, that I said at the very beginning that unless a gastric cancer is MSI high, even in Western world, we would not go for immunotherapy. That is the only funding criteria here at the moment. Okay, so let's come back to Bangladesh. And before I do that, a quick comment. In the keynote 061 or is it 062 had a Chinese cohort. I'm trying to remember. I think probably 061. And again, compared to the Western population, the Chinese cohort did extremely well, Now the question is, if we think about our genetics in Bangladesh, are we more closer to attraction group or are we more closer to keynote group? What would be your answer, Kamal bhai?
Yeah, mixed, we don't know.
No, actually, I don't know.
The first answer is we don't know. We are in the between. Okay?
And no one is very confident.
So which trial data is going to apply more on us? Is it the keynote trials or is it the attraction trials? But if we think about only the lung cancer, I know that in Bangladesh, there is a practice of female patients getting and responding better to the EGFR targeted therapy. Am I wrong to say that? Or
Yes,
is it okay?
yes, you're right.
Okay. So again, a lot of these PM patients, you do not do the AGFR status, do you? But I think there is a tendency to
Now we
treat
are
them.
not practicing. Before it was a practice. Now we don't practice without EGF because
Yeah.
it is not available.
Yeah. So again, the question is, if we can understand which way our genetics are behaving, is it more in line with the Chinese and Japanese people, or is more in line with the European people? I think anthropologically, we are Caucasians, aren't we? Even though I'm black as a black man. But anthropologically, we are more Caucasian. We are included in the Caucasian race. So should our biology behave more like Western people, or should our biology behave more like Far Eastern people, where they have a different anthropological race? What do people think here?
So I brought this intentionally because these are the unanswered question, because this racial issue is making a difference of outcome. So we don't know where we belong, but it has shown a big difference of outcome. That's what I intentionally brought it. So my message was that we may not have that much robust data for majority of them.
So again, in summary, Shumon, I think I will not very strongly recommend for immunotherapy. I'm keep saying that over and over, that unless you have a really strong case, and unless there is no financial toxicity, then you can consider it. But otherwise, there is no strong case to use immunotherapy. As I said, even in UK, our immunotherapy is only restricted to MSI high patients.
Thank you, Zaid. What about second line?
We can use first line or second line, but only in MSI high patients.
So you are very selective about the MSI high.
Yeah, as I've said, we are only going by the most robust data.
So do you really think in third line?
So if we look at the third line data, so you've got Keynote 59, which was a single term study, okay? And it was used after third line, fourth line treatment, heavily pre-treated. It did not have a control arm. So, and it did not compare against any standard chemotherapy. And let's not forget that we actually have Lonsurf as a third or fourth line treatment available in gastric cancer as well. The response rate of immunotherapy alone was 15%, wasn't it? Overall in the Keynote 59. But it was only a bit better, I think 14%, when the CPS score was 1+. So 14% response rate, and the toxicity, it is not what, is it?
So
Okay.
I got your answer. So indirectly you are saying that it is no. So yeah. I have got your point.
So the only positive trial was actually the Japanese trial, the Attraction 2. Okay, the Attraction 2 suggested some benefit. But again, if you look at the Javelin Gastric 300, where it was actually more real world trial, the Javelin 300, because you actually had a chemotherapy comparator, okay? And it was not any better than the chemotherapy. So in the third line, I think my answer is no. And the same thing that is a practice in UK as well.
So let us summarize with all your discussions. In the first line, if it is MSI high, so we can consider it, but there are lots of pros and cons, so we need to discuss with these patients. In second line, a little bit skeptical answers, and in third line, the answer is no. So there are some questions in the chat box. We are at the end of our program, so very quick questions to Professor Jahid Bhai. So HER2 expression, is it a good or bad prognostic factor?
So far, as I've said, that we haven't got any direct comparison with the breast cancer, but if we just only look at within gastric cancer, I think most clinicians will agree that HER2 positive gastric cancer behaves generally a bit better than the HER2 negative gastric cancer. That is our observation.
Okay. So then HER2 expression might be a good prognostic factor.
I think if the patients can afford it, at least as a clinician, that will give you some confidence that maybe this patient is likely to do a bit better than the HER2 negative. I think that information is helpful. I think that information may be helpful for you to have a prognostic discussion with the patient.
So this question was asked by Devras Chakraborty. Now there is another question from Arman Reza Chaudhary. Role of lapatinib in metastatic gastric cancer.
I am not aware that it is beneficial, and certainly it has got no funding, no license in UK to use it.
Box, Dr. Shumon.
Sir, please.
I have given the answer to the chat box, and there is no evidence that lapatinib is beneficial.
Right, sir. Right,
It was proven to be not beneficial.
right.
But the
Yes,
other drug that has been recently approved by FDA is trastuzumab deruxtecan. That has been
right,
approved in HER2 positive cases, right? That is
right,
recently
right.
approved by FDA.
Right. So for the Japanese population only, sir, still. So if I supplement to Armaniza Chaudhary, there are two trials probably, that is Titan and a Logic trial. They have tried lapatinib, but ultimately both these trials are negative. And not only the lapatinib, they have also tried in the TDM1 also, in the Gatsby trial probably. And ultimately it also comes with negative. So only the trastuzumab therapy that produce some better outcome. But besides trastuzumab, no hard-to-direct therapy produce any better overall survival. So that's all from the chat box. Thank you, Zahid Bhai. So
Can I just
if you,
make one comment is, I think
yeah, please.
Attraction 2 trial, they have done 2 years, 3 years update, and they have done an exploratory analysis on the HER2 positive patients, and they have shown that immunotherapy after those people who had HER2 target therapy before, it is still extended their life. So just an information, it's an exploratory analysis, retrospective analysis. So remember last time we talked about it, it's not a pre-planned analysis, but it just adds again one more thing, that the HER2 positive patients, they do better compared to HER2 negative patients.
So thank you, Zahid Bhai. Thank you so much. I know that you have taken a lot of hardship today to join this program. So thank you very much. Thank you. So we are at that end of our program. Now I would like to request Lucky Appa is there.
Lucky Appa.
So I would like to request Lucky Sinha, the senior executive from Sanofi, to say a few words. As you know, the Sanofi is our scientific partner. So Lucky Sinha.
Thank you. Thanks, Dr. Shumon. It's my privilege to have been asked for a vote of thanks in this interactive session. Sanofi always enhanced evidence-based treatment, and feel proud and honored to be the part of this excellent program organized by Oncology Club as a scientific partner. Dear honorable speaker, respected faculty and honorable experts, other distinguished doctors, and my dear colleagues, greetings from Sanofi, Bangladesh. My profound gratitude to Honorable Professor M.A. Hai, President of Oncology Club, for blessing us by his gracious presence. Heartiest thanks to the respected speaker, Dr. M. Jahangir Alam, MD in Medical Oncology, National Institute of Cancer Research and Hospital, Dhaka, for his excellent and evidence-based presentation on biological targeted therapy in advanced stomach cancer. Heartiest gratitude to Dr. Jahid Khan, Consultant Medical Oncology, Clatterbeach Cancer Center, Liverpool, UK, for enlightening the program by his expert opinion. Special thanks to Professor Mofazzel Hossain, Chief Consultant Medical Oncology, BRB Hospital, Professor Torit Kumar Somaddar, ex-head of Department of Oncology, Sher-e-Bangla Medical College and Hospital, and Brigadier General Mohammad Kudrati Lahi, head of the Department Medical Oncology, CMH, for their active participation and expert comments. Heartiest thanks to Dr. A.F.M. Kamaluddin, Scientific Secretary of Oncology Club, for taking the initiatives of this webinar and his valuable comments as well. Special thanks to Dr. Mustafa Aziz Shuman, Assistant Professor, Kumitola General Hospital, for his excellent coordination to conduct the program so smoothly. On behalf of Sanofi, I'd like to give a special thanks to all participants for their warm presence and active participation. In Bangladesh, currently we are passing through very critical situation. Nowadays, safety is our main concern. Hats off to all the frontliners who supported us throughout the pandemic period. Stay safe, stay healthy until we meet again. Thanks to all.
Thank you, Lucky Appa. Now it's time to say hear a few words from our chairperson. So Professor M.A. Hai, sir, over to you, sir.
Thank you, Shumon. Very much. We have spent the time very nicely. My thanks to Jahangir Alam, he has paper very nicely. He has studied and he has done a quite good job. Thanks to Dr. Jahid's aunt taking part from London, from UK. My prayers. Thanks to all the participants. I think we could know that still the chemotherapy is the treatment of choice for gastric cancer. And we are hard to treatment. Immunotherapy is still studied. One thing I'm sure that in the studies, patients are getting proton pump inhibitors or not. My experience, I could see that proton inhibitors creating big havoc in gastric cancer. You can put this patient off the guest from this proton inhibitors, possibly. But it might be, thank you all very much. Thanks to Sanofi for supporting us. Okay, goodbye everybody. Love it.
So thank you, sir. Thank you all for participating. Our next topics will be on a different time. As you know that there are some options for the advanced metastatic cancer, that the PIPEC, HIPEC. So we will see some real life case scenario and some discussion will be on these topics. Our next presenter will be Dr. Shahriar Kollon, a very promising surgical oncologist, assistant professor working in cancer and right now working in the National Cancer Institute. So before closing, I would like to give a special thanks to Jahid Khan Bhai. And I would like to request if he can present in our very regular sessions. I know it will be very difficult, but it is very easy to interact you as you are very close to us by virtue of the Bangladeshis. And so I think you should try to be present in our every session if your very tight schedule can allow us to join. So thank you. Without any further delay, I would like to request every participant to join our next program. Stay safe. See you in next Sunday. But one announcement, from next Sunday, our program will be start on 3 p.m. instead of 3:30, as it is Ramzan. So we will start our program on 3 p.m. So till then, stay safe. Thank you.